Welcome again, our colleagues. We will start a new pediatric session today. This is a pediatric genitourinary system, especially the renal system. So it is today cases is a pediatric related diseases. I mean congenital genitourinary diseases. Candidate number one, 20
Yes,
years old male patient presented with bilateral flank pain.
okay. Okay, I'm provided with the X-ray abdomen frontal projection of a 20-year-old male patient presented with the bilateral flank pain. And in this provided image, uh, I cannot see any obvious pathology noted in bilateral renal regions. However, I'm trying to look at
Raise your
bilateral.
voice, please. Doctor, raise your voice.
Okay, sir. I'm provided with X-ray for abdomen, including pelvis, frontal projection of a skeletally mature patient, of a 20-year-old male patient, in which the patient presented with bilateral flank pain. And in this single provided study, I cannot see any obvious calculus or any radio density noted in the expected position of bilateral kidneys. However, I am tracing the ureteric course or course of ureters. The sacroiliac joint appears normal. However, there is some gas shadows obscuring the pelvic regions. So this is basically IVP study. This is the initial film in which I can see that there is a pacification of bilateral pelvic radial system, and there is mild narrowing noted at bilateral pelvic-ureteric junctions. However, the contrast is passing into the renal pelvic radial system, and I can also see that there is no significant filling defect noted. The bilateral renal outlines are normal, and the contrast is taken up by the kidneys normally. There is some faint cupping or lobster claw deformity noted in the bilateral renal pelvic radial system, more prominent on the left side, but there is some distorted calluses noted on the left side as well. I would like to see confirm it on other images, whether it is being pronounced on other images as well. Sir, can you please show me further study? Okay, on the more delayed films, I can see that this deformity is more pronounced. So this is basically a lobster claw or T on a ball deformity, indicative of renal papillary necrosis. And I can also see that there are some paintbrush sort of striations noted in the right lower pole renal calluses also. And I can also see that there are tortuosity and mild.
Doctor, 1 second.
Yes,
One
sir.
second.
Yes, sir.
This is the paintbrush.
Yes,
Where
sir.
is the lobster?
Sir, this is giving me some the right. Can I please, sir, ask for the mouse?
Yes, sure.
Yes, sir. I'm asking.
Request.
Right. Yes, sir. I have requested. Sir, here I can see that there is a mild T on a ball sort of appearance at this calyx. And on this side, there is mild deformity of the callus is also noted, but more pronounced
1 second.
deformity.
1 second. Where is the
This
paintbrush
paintbrush.
sign? Where is the paintbrush?
Sir, this one,
Only?
not, no,
What about
sir, no, sir. This here it is also seen,
where?
and on, sir, in the lower pole calluses of the right
Give
kidney
the
and on the
mouse.
left kidney.
Give the mouse. What
Okay,
about
sir.
this one?
Sir, which one? I cannot see your mouse, sir.
The right middle calyces.
Yes, sir. There is also.
Okay, and what about this? But it is very faint. And what
Yes, sir.
about this? And this is very faint. See, I think يعني, it is looks like a lobster sign, but يعني, see, we can't judge 100% this is a renal papillary necrosis.
Okay, sir.
Okay, we can't judge, but the most prominent sign here, paintbrush sign.
Paintbrush.
Okay.
Paintbrush. Yes,
See,
sir.
let us follow the Radiopedia يعني guidance. They didn't mention anything about renal papillary necrosis. Anything. Even I have a
Okay.
doubt also about this. Is this filling defect? Okay, but finally they talk only about paintbrush sign.
Paintbrush.
Okay,
Okay, sir.
so give me your differential diagnosis.
So paintbrush striations are seen in medullary sponge kidney, and they are also seen in, I think, infections such as
Mhm.
other. I guess there is also renal vein thrombosis is also one of the cause.
No,
Uh,
no. See,
so medullary sponge is my first diagnosis.
yeah, middle response kidney.
Yes,
Okay,
sir.
it it may be seen in renal tubular ectasia.
Okay,
Okay,
sir.
but what is the most common? The most common is medullary sponge kidney.
Medullary sponge, yes, sir.
What is the common association with medullary sponge kidney?
Common association with medullary sponge kidney. Sir, I'm not sure about it, but there is.
I will
I
help you. Can I help you?
Yes, sir. Please.
We have I have run many pediatric sessions this week.
Yes, sir.
I
So
think so.
Carol
Yes, excellent. And
Yes,
what else? Something in GIT also.
yes, sir. GIT, Carolese disease, and
One disease, the first letter of it, C also.
sir, hyperparathyroidism.
No, I just announced something in the beginning today about this disease. Congenital
Mm,
hypertrophic.
HPS. Okay, okay, okay. Congenital
No, sorry,
hypertrophic.
sorry. Congenital hemihypertrophy. Sorry, sorry. Congenital hemihypertrophy. So, middle response kidney highly associated with Caroli disease and congenital hemihypertrophy and
Okay,
Ehlers-Danlos syndrome.
okay, sir.
Ehlers-Danlos syndrome. If you told the examiner one of them, you will be a great doctor. No need for
Oh,
all. If you retain one in your brain, this is very good. Look here, my colleague. This is the control film. It is almost normal, but here we must follow. Here there are some paintbrush, and here also here. Then ask for magnification, please. This is very important. Very important. All the calyces has a medullary sponge kidney affected by the paintbrush sign appearance. Okay?
okay,
Then
sir.
we will transfer the patient to the renal, pediatric renal or kidney MDT.
MDT.
Uh, Thank you, doctor, so much.
So
Next
can I
slide.
ask a question, please?
Yes, yes.
So why are the callicial system on the left side seem so distorted?
Uh, See, this one is good. This one is good. Here it is, see, there are some confusion because this is the medullary sponge kidney, this one, and it is
Yes, sir.
almost obscuring the normal minor calyces here and also here.
Okay,
Yeah.
sir.
This is my explanation, by the way.
Okay, sir.
But
Thank you, sir.
the Radiopedia didn't mention anything about this case, so it is better to follow exactly what is written.
Okay, sir. Thank you,
Okay.
sir. Thank you so much.
Welcome. Next candidate. My colleague, by the way,
أسا-
عليكم السلام. Medullary sponge kidney is a developmental, يعني the disease is caused by developmental defect in formation of the collecting tubules. Okay? The collecting tubules. Then it results in cystic dilatation of the medullary and papillary portion of the collecting tubule. He means this one. يعني I'm reading by the way from the Radiopedia. Again, I will explain first. the abnormality here in the collecting tubule and in the papillary. The papilla, this is the papilla. This is the papilla. Okay, what happened here in the papilla? It looks like more planting. Okay, but this planting not the same planting the same planting appearance of medullary of tubular necrosis. It is due to the dilatation of tubule. So I think the size of this papillae is increased. This is according to the radiopedia explanation. It is very important to follow a textbook. See my colleague here, this is very important. Read here. Another spongy kidney in the pathology. This one, what happened? And this is an answer for your misinterpretation, interpretation, my doctor. See, and the result in cystic dilatation of medullary and papillary portion, the papillary
Okay.
portion of the collecting tubule. So the papilla looks like wide. The papilla
Okay.
here looks like blunted. So our colleague consider it at the beginning as the planting appearance of the papillary necrosis.
Yes.
So this is a new information for me even. For all of us, when you see the brush painting sign or the pen brush sign or appearance, don't worry about this planting. This is
Okay.
this is a broadening or expected planting due to cystic dilatation of the tubule here. This is not
Okay.
this is not papillary necrosis.
Okay.
Very new information and very good, by the way. Thank you, doctor, so much. It was
Thank you.
a medullary sponge kidney, the most common association again, Caroli disease. Again, Caroli disease and Ehlers-Danlos. Next candidate.
Assalamu alaikum, sir.
Salam, ask the mouse, please.
Sorry, sir, I am on mobile.
Yes, doctor, this is 15-year-old male patient presented with hypercalciuria. Go on.
I am presented with the CT KUB plain images. I
Yes.
can appreciate medullary calcifications, which are dense and involving in bilateral symmetrical fashion in both kidneys.
Okay.
Both kidneys are normal in size. There is no dilatation of pelvic ileal system, no hydronephrosis, or no hydroureter seen on the visualized sections.
Okay.
Rest of the structures are normal, like liver and visualized spleen and gut.
Mm-hmm.
So, in conclusion, it's a case of medullary nephrocalcinosis.
Yes.
I would refer this patient to the genitourinary MDT, renal MDT, for further to rule out its cause. The main causes in this case is the first cause is the renal tubular acidosis, which
Okay.
is the most common cause of medullary nephrocalcinosis. Other is medullary sponge kidney and hyperparathyroidism, hypercalciuria, and hyperuricemia. These are all causes of the medullary sponge kidney.
Okay.
Yes, sir.
1 second. 1 second. Tell me some other causes of medullary nephrocalcinosis. You told me medullary sponge
Sir,
kidney. Oh, some other causes.
sir, renal tubular acidosis is the most common cause.
And what else?
Hypercalcemia,
What else?
hyperparathyroidism.
Okay. How do you differentiate between them from this city?
Sir, I would like to see the bones of this patient.
Okay. This is the bones.
In the bones, there is a scoliotic deformity of lumbar spine having convexity towards the left side,
Yes.
and there is reduced bone density in the pelvic bones with small lucent lesions. which is involving the both iliac bones and the upper end of the femoral, visualized femoral shafts and head.
Okay,
I would
give
like
me
to see the.
one
I
answer.
would like
Is
to see.
this hyperparathyroidism or not? Is this usual?
Sir, it looks hyperparathyroidism.
Look at the vertebrae, please, before you judge.
Okay, so sir, I would like to see the sagittal images if available.
No, no, no. This is enough. Hmm.
But I didn't see the rugged jersey spine in
Okay, so
this case.
is this hyperparathyroidism or not?
Sir, pelvic bones shows reduced density and multiple
Yes or
lucencies.
no? Yes or no?
Sir, I think yes.
No. Why? Uh, did you find any regular jersey? No. Did you find any sub preosteal resorption? I think no. Brown tumor? No. Okay, so this is another metabolic disease which affects the skeletal system and the kidney. Okay,
Okay, sir.
and do you think it is common to find this pelvic deformity in hyperparathyroidism? It
No,
is
sir.
familiar. So this is not the usual hyperparathyroidism. This is the most common cause, renal tubular acidosis. Doctor, why is this not stones? Sometimes in ultrasound, really, we diagnose this calcification as stones. How could we differentiate between stones and medullary
So
calcinosis?
usually in medullary nephrocalcinosis, no posterior shadowing seen, and stones are not in symmetrical fashion usually. But it can be,
This
but
city.
there is no
No,
posterior caustic
see,
shadowing.
see, I'm talking about the city. How can you give me a clue, a differential clue
So
between?
these are in the medullary pyramids, basically, not in the tubules.
Okay. Do you want to do
In the
another?
not in the pelvic ileal system.
Okay. Do you want to do something else to differentiate between both of them?
Sir, I would like to take the density.
Okay, but do you want to do something else for this city to be sure?
CTIVU. CTIVU in this case, if they are stones, then filling defects are seen. And in medullary sponge kidney, these are
Excellent.
the pyramidal calcifications.
You are brilliant. I'm waiting for one buzzword, feeling defect. Okay? Despite
Okay, sir.
this feeling defect, the contrast will be very similar to, يعني, very near from the stone, but the stone is denser. Okay,
Okay, sir.
stone. We talking about the stones, but if in this case medullary nephrocalcinosis, you will see the normal pelvic calcial system very normal, like
Yes, sir.
like had been drawn by handwriting. Okay, you will see everything is very normal, and the stone is
Okay, sir.
outside. Sometimes we can ask for reconstruction. يعني if you ask your technician, if you give contrast and then ask him, please do me 3D subtraction for the pelvic calyceal system and the ureter, he will exclude or he will reconstruct the system without these stones. All of these are minor technical question which may be asked in the exam. Why? The examiner wanted to know, are you only study or you do some practice or you are working in one hospital? Okay. From this
Okay, sir.
question,
Thank
you
you.
can pick up your knowledge. Thank you, doctor, so much.
Thank
It's
you so much, sir. Thank
case
you.
of medullary nephrocalcinosis due to renal tubular acidosis, which is the most common cause. Doctor, a last question. Sorry.
Yes, sir.
What is the difference between medullary sponge kidney and renal tubular acidosis? There are one differential point.
Sir, sir, in renal tubular acidosis paintbrush sign.
Oh, no. Uh, what
Sorry,
again?
in medullary sponge kidney is the paintbrush sign,
Okay.
like I see in the previous one.
What else? What about the size of kidney? Which one of them is normal size, not reduced?
Uh, Middle response kidney, normal size.
And the renal tubular acidosis?
I think they are reduced in size due to chronic disease.
Okay. Okay, my colleague. See, in all type of medullary nephrocalcinosis, the kidney is small, except one type. Except one type, I think almost as our doctor said, medullary sponge kidney. It is only normal size. Only normal size. Thank you, doctor, so much. Next
Thank you, sir.
candidate.
Thank you.
Next candidate.
Assalamualaikum, sir.
Alaikum salam. Doctor, this patient, 15-year-old, has polyuria. Sorry, not this one. Again, sorry. A child who has recurrent urinary tract infection.
I am provided with multiple multiple images of nuclear study of the kidneys, in which this is a dynamic DTP scan, I think, MAG3, performed with the MAG3. So I can appreciate that the left kidney is showing increased uptake of contrast, and the contralateral kidney is of normal size, and the contrast seems to progressively increase in the density, and the kidney is not excreting the contrast. I cannot appreciate any renal pelvis or the ureter. So keeping in view the continuously increased uptake in the one of the kidney, this is likely obstructed. The clinical concern is in this case is obstruction due to complete pelvic-ureteric junction obstruction, or uh, I would like to correlate this with the ultrasound of the patient, and the contralateral kidney is of normal size
What is
with
your next
small
step,
uptake of contrast.
doctor? What is your next step?
So next we can correlate this with the ultrasound to confirm the
No,
cause of
for
the.
ultrasound, you should do something here. Something.
We can see their different curves, which is depicting the different ratios,
Okay,
whether the
so
kidney
see,
is
I
obstructed
will
or
help
not.
you. I will help you. You must give the patient
Okay.
something.
Uh, we can give patient diuretic so that the contrast excretion
Yes.
can be accelerated by the medicines. And if still there is no contrast excretion on the kidney, then this
Mm.
confirms our diagnosis of complete pelvic-ureteric junction obstruction.
Okay. Look here. What happened?
So these are the ROI which are placed on the different kidneys, and I can appreciate that.
What is this? What is the
So
name of
these
this?
are the dynamic curves, flow curves, and tell us about the function curves of
Mm-hmm.
the kidneys. One of the kidneys obstructed.
What is the name of the
Yes.
study?
So this is whole known as dynamic nuclear study of the kidneys,
See, this curve is
MAG3
the name
study.
of this one. Okay. And this is okay,
Okay.
this is dynamic. But what is the name of the tracer?
So MAG3,
Okay. So this is Max 3 study. And
yes.
the this is the curve. You can call it, for example, renogram. Okay.
Yes, Reno. Yeah, okay.
What happened?
So in the flow to the kidney uh, on the right side is normal.
Hey, look here
However,
first. See, what I will help you. Look here. The round, the round one, this one is the right
okay,
one. And
okay. The
the
smaller one is the left one.
the
Okay,
polygonal one is the left one. So This is the left one. This is the right
Yes.
one. From the beginning, where is the normal? This or this?
Sir, right kidney is normal. Left kidney is
No, no, no.
okay, okay.
The round,
Yes, yes,
the
yes,
circle is the right, which is this one.
yes.
The
Okay,
polygonal is the left. Which one is normal?
yes.
The up or the down one?
Sir, the left one is normal because it is taking the contrast and
Okay.
excreting the contrast
So
normally, but the right one is
we will
only the
talk,
taking contrast but no
okay.
excretion.
We will talk about this, not this one. What happened here?
So it is continuously taking up the contrast without excretion.
Okay. Without excretion. But before taking up, there are something here. What is the name of this part of the curve? What happened here?
This is the maximum ability of the kidney to take up the contrast,
Okay,
and
the
then it
peak.
starts.
Peak. There are a peak here or no?
Okay. Yes, there is peak.
Here, in the abnormal kidney. There are
So
peak or no?
no, no, no,
So,
no peak in the
okay,
right
this
kidney.
according to the peak. And what happened here? Compare this one and this one. Till here, this is the uptake. Till here.
Okay.
And from here, down, 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 this is the excretion. So any renogram, you must describe at least two part. The uptake,
Okay.
including the peak, and the excretion. So tell me about the uptake. What happened? Is this normal or abnormal?
So the uptake is also abnormal. It
Okay.
is not normal.
Is
It is
this
no, with
slow,
normal.
slow or increased?
This is slow uptake.
Okay, very good. So number one, there are slow uptake and even no peak. No peak.
Yes.
Then what
Okay.
happened? Stationary. Ex
Yes.
What is this? This is the excretion. What happened for this one?
Okay. So
What?
this is static,
Excellent.
but not
What
excreting.
does it indicate, my doctor?
Uh, Complete obstruction of the kidneys with
Okay.
prolonged obstruction can lead to the compromised
Yes,
function of the
yes.
kidney as well.
This plateau. Excellent. This
Okay.
is this is indicate complete obstruction. This is a plateau. What does it indicate? Indicate nearly no excretion. Why? Till here we uptake, 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 like here. Despite it is very weak uptake, and then no excretion at all. Till here, no excretion. Okay. So there
Okay,
are
sir.
retention of the tracer. Okay, my colleague. So this is
Okay,
max
sir.
3. By the way, I prepare one lecture for nuclear, one or two lecture. We will
Okay, sir.
vote because I think it is one of the most important that not covered well on the YouTube. I will do at least two lecture for all different modalities of nuclear scan. Okay, my colleague. So give me
Okay.
this is the ultrasound that you request. What happened?
Yes. So in the ultrasound, I can appreciate partial fit urinary bladder. The right kidney is normal, and the left kidney shows moderate dilatation of the pelvic liver system and renal pelvis.
Mhm.
So there is abrupt narrowing at the level of pelvic-ureteric junction. I am unable to appreciate the proximal dilated ureter, and I cannot appreciate any calculus or mass in the region of the pelvic liver system or renal pelvis. So this is a case of complete pelvic-ureteric junction obstruction with resultant echogenic left renal parenchyma. And the cortical thickness is borderline, which is 1 centimeter at the mid pole of the kidney. So I will urgently refer this patient to the orthopedic urologist for further management and pyeloplasty of the patient to relieve the symptoms and follow with ultrasound
Doctor,
after.
you mean pediatric urologist? Huh?
Yes, sir.
Yeah, because I listened something else. Doctor, could you tell me any type of etiology in neonate or in pediatric age group for this PUG obstruction?
Sir, there can be in utero, there is a developmental problem with the normal formation of the renal pelvis. Um,
Okay,
uh, this can be secondary to ischemia, but I don't know the
excellent.
exact cause.
What else?
Yes.
What else? Excellent.
The chronic infection can lead to the further stenosis and narrowing, like chronic pyelonephritis in the pediatric age group
No,
patient?
no, 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 no. What else in utero? You are in the correct pathway. In utero,
There can
you
be.
talk about
Okay.
ischemia. What else? See, this is, I will help you. And see, my colleague, it is very important. This is the pelvis and this aorta. Any obstruction of any tubular structure, think in its component. Do you remember in the bronchiectasis, either from outside or from the wall or from the inside? Okay,
Okay.
so
Yes, sir. So,
let's talk about outside.
outside causes, which I remember, is the aberrant course of the renal artery or vein
Okay, and
can
this very
also cause the,
very common, by the way. What else?
yes. Um, mm, the third pathology came into my mind is the retrocable ureter, but the obstruction is at the level of proximal ureter, not
No,
at the
no,
level
no,
of
خلاص.
renal pelvis.
Outside is only by crossed vessels. Okay, from the mure,
Okay.
from the wall itself. Number one, you told me about the ischemic insult. Very great. What
Yes.
else?
Yes.
Hmm.
There can be some mass in the wall, or
Or abnormality in the muscle itself. Okay, or
yes,
maybe
sir.
a fold from the epithelium. Okay, thank you,
Okay.
doctor, so
Okay.
much. Why I ask my colleague this question? This very difficult question. Why? To teach all of us how to guess. By the way, this is the first time this question is asked, but we are learning. I'm trying to learn all of you about how to guess. Even inside the exam, you can guess something, but by logic. Okay, this is a tubular structure, so think outside and from the wall, and it is very difficult to be obstructing mass from inside. Okay, thank you, doctor, so
Okay, sir.
much. Um,
Thank you.
Thank you. Next candidate. Next candidate.
Assalamu alaikum. Assalamu alaikum.
Wassalam. This patient presented with abdominal distension. 9-year-old.
Okay, this is X-ray,
Yes.
lumbar spine, X-ray kidneys, frontal projection
Yes.
in a 9 years old patient, in which I can appreciate that on this plain study there are markedly enlarged renal outlines, um, particularly on the left one, with it is right nephrogram. It is the right nephrogram phase in which there is a dense nephrogram on the right side, which is normal according to the phase. And on the left side, there is enlarged kidney with uptake in the cortices, but the uniform uptake is not seen in the renal pyramidal region. So I would like to see rest phases of the study to comment on the excretion of the left kidney further. This is the renal pyelogram phase of the same kidney, multiple phases in which I can appreciate that there is normal filling of the pelvic ileal system on the right side and excretion of contrast on the right side. However, if we come to the left side, there is a markedly lobulated outline of the pelvic ileal system with some filling defect in the mid and lower poles. There is abrupt disruption of a contrast at the level of pyloureteric junction, and I cannot appreciate any passage of contrast beyond this region. Sir, I would like to see further images as well to see any contrast excretion. I would also like to see prone images to see that whether it helped or not. In this 1 hour film, still there is no excretion, no outline of the left margin. The bladder is partially filled, and the part which is filled is showing some thickening along the dome of the bladder, suggestive of cystitis, and it is also more on the left side of the bladder. Uh, Sir, can I see post excretion films and the plain films as well?
You want the plane again? This is the last film we have, and this
Okay,
plain film.
this is the plain. Okay, sir, on the plain film, there is no radio density seen in the line of the pelvis or ureter, and however, the left renal shadow is also enlarged. Sir, I would like to see once again the post contrast, post
What is the name of this phase, doctor, by the way?
Sir, this is the renal pylographic phase.
Okay, but
Early
look here,
15 minutes film.
look here. This is,
Excretory phase, sorry.
yeah, 15
Excretory phase.
minutes. See, no, I think as the bladder is start to fill, you can consider this delayed, but delayed
Delayed.
according to 15 minutes, 20, 30, 1 hour, 24 hour. Okay, because excretory phase, you must see the kidney first uptake in the first 3 minutes. Then, uh, could you know the normal timing of the IVP? And
Sir, IVP is done as plain and then 3 minutes film, 5 minutes film, 15 minutes film. If the excretion is not seen on one or either both sides, then
no,
we do
no,
a probe
tell me,
view and
no,
then
no, tell me each phase by its time.
sir, it is done in 5 minutes after giving the contrast injection.
Mm-hmm.
3 to 5 minutes to see the nephrographic phase.
Okay, okay, complete your case, and I will tell you something about the IVP.
Um, Okay, the this IVP concludes that there is a markedly enlarged left kidney with dilated pelvic calyceal system with no excretion seen on any of the post-contrast, any of the delayed images, and ureter is not outlined. There is
Mhm.
particularly abruption at the level of pelvic ureteric junction. So I
Okay.
believe that this is a case of left PUJ obstruction with gross hydronephrosis and delayed excretion. I would next try to correlate with the ultrasound images of the patient to see the status. There is, however, no filling defect. And next, I will advise next 3 study to see the function of the kidney and will refer the patient to pediatric nephrology MDT for further management.
What's your differential diagnosis?
My differential diagnosis is um, post post-infective or any due to aberrant vessels. It's at the level of PUJ and for a long-standing time, resulting in gross hydronephrosis. So it's not acute process.
Yes, yes.
So,
Tell me the original pathology. What's your diagnosis?
insert pelvic ureteric junction obstruction or narrowing
Okay, doctor.
without any calculus in this particular case.
Okay, doctor. Thank you so much. See, my colleagues, IVB is very important, and it is because most of the examiner are elder. They did a lot of IVB. So all of us must know the phases. Number one is the cortical phase. Some examiner ask about it and some not. Okay, because it is very early, about I think 1 minute. But the most common, they start with nephrogenic or nephrographic phase, which about 3 minutes. Then 5 minutes, after 5 minutes, this is a secretory phase. Secretory phase. Okay. What mean by secretory phase? Means that you will see all the kidney is opacified, and start to secrete something here, but not like this. Okay. Because the secretory phase is about 5 minutes. Okay, my colleague. Um, number three is the 15 minute, 15, 30, 45. All of this are delayed, but delayed with biolograph, ureterograph, cystograph, okay, according to ability of the kidney to fill the ureter, pelvis, and urinary bladder. Okay, my colleague. So here there are persistent nephrogram. This is a very important buzzword. I bring this case to listen this word. Very important. Persistent nephrogram. What does it mean? It means the contrast is still in the kidney, in the glomeruli, inside the kidney tissue itself. Very faint. See, this is 15 minutes. Very faint contrast in the pelvic LCS system. Faint. Compare here and here and here. Okay, my colleague. The persistent nephrogram is very important sign of obstruction. In some practice, we can tell the examiner we can give Lasix to differentiate between mechanical obstruction and the non-mechanical. But in pediatric age group, because it is almost BOG obstruction, better for you to tell the examiner something about it. Okay, my colleague. So it is another case of BUG obstruction. BUG obstruction, but here in IVP. Thank you, doctor, so much. Next candidate.
السلام عليكم.
Alaikum assalam. Doctor, could you request control?
Sorry, I don't have control. I'm on my mobile.
Okay. Doctor, this 35-year-old male patient presented with abdominal pain. This is static images. Look, look, look here, here, and here. What happened?
Okay, I have been presented with static images of MRI for an pediatric age group patient with abdominal pain. I noticed that there is dilatation of the biliary tree, including the intrahepatic biliary ducts and the common hepatic ducts. I noticed that there is a few filling defects are noted within the common hepatic ducts. Appearances are mostly those of stones. Can we scroll the images again?
Not scrollable, static.
No. I mean to look to the previous images. Yes. Here's I can see that there is a few cystic rounded lesions noted within the liver, within the right liver lobe, and also I can see that there is intrahepatic biliary dilatation at both liver lobes. There is no edematous changes seen surrounding this cystic lesion, and I can see that the liver surface looks smooth and not irregular or nodular. Can we scroll to the next one? Yes. Here I can see that there are multiple filling defects within the common hepatic ducts and also within the common biliary duct. Can I see the previous one? Because I noticed something within the kidneys.
Look here or here. Look here.
Yes.
Or you mean this one? There are no kidney. Yeah, you can pick up a little part of the kidney, but here. Oh, look here.
Yes. Here
Yeah.
I can see that there are multiple hyperintense T2 signal within the both kidneys.
Yes.
That replacing the normal corticomedullary differentiation, or there is loss of the corticomedullary differentiation. Appearances are could be those of medullary sponge kidney.
Okay.
However, I will look to the other sequence and images for better evaluation, and this is associated with multiple stones within the biliary tree.
Okay. Give me your final diagnosis, please.
Medullary sponge kidneys associated with multiple biliary stones.
Doctor, what is this? Look again. Look again. This is just stones. Okay, there are stones.
No, there.
But what happened?
Yeah. There is. Yes, I think here I can see that there is dilatation of the biliary duct with areas of alternative stenosis and dilatation in the biliary ducts, which could represent changes of primary sclerosing cholangitis.
No, no.
Sorry, I can see that these lesions appear connecting to the biliary ducts.
Yes. Oh,
Yeah, it could be those of, but unlikely biliary hematoma. Other differential diagnosis could be those of Caroli disease, but unlikely because I cannot see the central dot within these lesions.
okay.
Other
If you didn't see the central dot, what's your explanation about this test? See, doctor, we have a medullary spongy kidney, and we have intra or intra and extra, hmm, intra or intra and extra
uh,
biliary cyst.
and I think intra only. I cannot
Okay,
see one in the extra.
okay.
So it could be part of the colloidal lesions.
Yes, this is
Uh,
cyst, but this is Caroli disease. Very easy.
Caroli disease, yeah.
Why? The Caroli disease is the only one that the biliary intrahepatic biliary duct cysts. And look here, doctor. This is the central dot sign here. This one.
Okay.
Is it clear?
Okay.
Okay.
Yes, clear, yes. Yeah.
Okay. So my colleague, it was a Caroli disease associated with this one. Great case. Bilateral. Doctor, somebody will tell me, doctor, it is very difficult. I didn't see the exact paintbrush like a bit. Okay, see, don't wait from the examiner to give you a typical case with like the textbook describe. You will find something here. What is this intrahepatic biliary cyst? And just one of them has this very faint central dot sign. And just both kidneys has abnormalities. What is this abnormalities? This is looks like white signal and some striation. Doctor, it looks like dilated tube. Okay, very nice till this point. So try to help yourself, my colleagues. Try to help. Try to squeeze your brain. What is the most common condition that contains these two pathology? Carolo disease and medullary spongy kidney. You will never find a typical case like described in the textbook. Even if you told the examiner, if you have told the examiner, doctor, it may be Caroli and the medullary response. Okay, you are in the correct pathway. No one asked you, no one asked you to give a pathological definite diagnosis. Okay? So at least give two possible differential for each case. If you are not sure or if you are hesitated. Okay, my colleague. Thank you, doctor, so much. Next candidate.
Good afternoon.
Good afternoon, doctor.
So I've been presented with one of the films of IVU, I guess. As I can see that there is significant contrast is seen within the urinary bladder.
Yes.
And I can see that contrast is also seen within the ureters. With left ureter appears dilated and tortuous, with contrast is seen within the pelvic ileal system bilaterally, with clubbing of the calyces on the left side.
Yes.
In summary, I need to know any further films to confirm my findings. So may I have other film if available?
Okay. 1 second, doctor. Again, because one of our friends is asking, the last case was Caroli disease and medullary spongy kidney. Okay? Caroli disease and medullary spongy kidney. Why we should better to start with this is a Caroli disease? Because MRI is very diagnostic to Caroli disease. Medullary spongy kidney may need some contrast studies to be 100% sure. So we start our diagnosis with the most related to our study. Okay, our colleague, my friends, which study is this? The previous one. The previous one. I will show you. Please, my colleague. Please, my colleague, if you have an urgent question, ask me at the case. This one. I'm talking about this one. The dominant pathology here is renal stone and Carol disease. And this renal abnormalities, it is almost medullary sponge kidney. I'm talking about this one. Okay, sorry, doctor, for interruption. Go
No
on.
problem. Thank you.
This is other.
Okay, so this is sending, this is a sending cystogram to, as I can see, catheter within the urinary bladder. So, but I cannot see micturating part of the exam. So I'm suspecting this is reflux of the contrast within the pelvic ileal system, which is more on the left side, with clubbing and dilatation of the left renal pelvis and tortuosity of the ureters. So I'm suspecting this is grade 5 reflux with so I will further evaluate this patient with ultrasonography and check the clinical history of the patient, how the patient is presented, and further referral to the pediatric urology team is suggested in this case for further evaluation treatment.
Okay, doctor. But doctor, what is the name of this sign, please?
This is dilated renal pelvis. So
Yes, it is dilated. But normally you see the right kidney and the left kidney. Which one
yeah,
is more higher? Normally. I'm talking normally.
normally left is more higher.
Okay. Which one here is more higher?
Okay, so right is higher than the left. So
No.
as I can see
No. Which one of this film is more higher? Left or right?
on this film, right is higher than the left.
Why? Do you think the abnormality in the right or in the left?
In the left.
What happened?
So I may check the control film, so I can check the size of the kidney on control film. It
No
may
need
be
for control
enlarged.
film. See. No control. No need.
So if it is enlarged, then
See, I will
it may
help you. See,
duplex.
let me help you.
Okay.
This pelvic cell system is dropped downside. Why?
So it may be a duplex kidney.
Yes.
So
What is the name of this sign?
drooping Levy sign.
Excellent. How can we pick up this one? See, I can excuse you today, all of you, for any mistake, because as I told most of you, the pediatric is really difficult. Today, it is allowed for all of you. I think we didn't have any candidate of John. All of them finished their exam. So it is allowed for all of you to make any mistake, no problem. It is difficult. But we must learn from our mistake. What happened here? This is ascending. Doctor, your answer is duplex kidney. Okay. I will ask you one question and then I will explain some tips about this case. Tell me about this kidney, duplex kidney. What happened in duplex kidney?
I cannot see the upper moiety ureter. So
Why?
it may
Why?
be because it may be non-functioning or hydronephrotic part. That's why it's causing pressure on the lower moiety.
Excellent.
And
You means the upper moiety is obstructed. That you means, correct?
Yeah.
Okay. Why it is obstructed? Where is the exact insertion of the upper moiety ureter?
The upper moiety ureter insert into the at normal position.
Excellent. So it is
With maybe ureterocoel, and the lower moiety ureter insert ectopically, so it may insert into the urethra
No,
or
the opposite.
into the.
No, the opposite. The upper moiety has ectopic insertion, by the way. Upper moiety. One has ectopic insertion and it almost obstructed. So it is hydronephrotic and non-functional. The lower moiety has a normal trigonal insertion. Okay?
Okay.
Okay? And it may have some reflux. The lower moiety ureter may have some reflux. The opposite, see, both moiety are completely opposite. The upper one has abnormal insertion and has stenosis due to urethrocyl. The lower moiety has normal insertion and it may have some reflux. That is
Yeah.
okay?
Yeah.
What is the explanation of this drooping lily sign?
Because due to the hydronephrosis and the non-functioning kidney, it exerts the pressure effect on the lower.
Brilliant.
Uh,
Excellent, doctor. Excellent. Thank you, doctor, so much. One tip, my colleague. First, you should see, is this IVP or there are a urethral catheter. Okay, this is urethral catheter. Hey, this one, almost this urethral catheter. Okay, so it is not IVP. Okay, my colleague, what is this? It is ascending cystourethropy. We should also here, I think, here it is catheter. This one. Okay. Second, you showed in pediatric. Here we look here at the epiphysis. This is pediatric. So you should check the anatomy. Is the left kidney is more higher than the right? Yes, خلاص, you exclude this dropping lily sign. But if the opposite, like this case, so from the first second, you will pick up the answer. How? Because you follow a standard technique or a standard style. From like, see, do you remember in the chest, in the babygram, I told you look from the neck, then chest, then abdomen. Like here also, look from the position. First check is this IVP or ascending cystourethropy. Then check at the position of both pelvic cell system. Then look at the bladder. If you use the proper technique, really many subtle finding or many confusing finding, you will not miss it. This is a dropping lily sign due to hydronephrotic non-functioning upper moiety. Okay, my colleague. Thank you, doctor, so much. It was a difficult case. Why? Because it is a subtle sign. Thank you so much. Next candidate.
Yes, sir.
1 second. "35-year-old female patient has hematuria. Look. See, my colleague, this is nephrogram, by the way. See?
Okay.
What is this? What is the name of this phase?
Excretory phase.
Okay. And byelogram. Okay.
Pyelogram.
What is the
Yes.
name?
This is excretory phase. I can see contrast in the ureters and
Yani
early filling of
more
the.
delayed than execrate. Yeah, okay. You can consider it early delayed because 10 minutes. Okay, see here.
Mm.
Okay, 15 minutes. And this is control film. Okay. Yeah, tell me.
All right. So on the control film, I can see that there are two calcific densities on the control film in the region of the pelvis.
Yes.
Over here, and also a calcific density is seen in the upper pole of the left kidney. These represents ureteric calculi in the region of the ureteroceles, because on the subsequent images, I can see that there is contrast excretion from the double pelvic ileal systems. And there is, can you show me the excretory phase once again? All right, so contrast is seen excreting from the bilateral ureters. However, in the left upper pole, there is hydronephrosis and more obstruction. There is more significant ureter, but there are bilateral ureteroceles.
Doctor, you mean this one?
Yes, this upper pole,
I think
mild
I think the
hydronephrosis.
ureter is almost not too much dilated, correct?
Yes,
Maybe some
yes,
fullness like this. Okay, see? Okay,
yes,
I'm agree with you. It is there are some dilatation, but not the considerable significant dilatation. Yeah, go on.
yes. Okay, and there are bilateral uteroceles, which are showing early filling of the uteroceles, giving the cobra head appearance
Thank you,
in the
doctor.
region of the
Doctor,
urinary
doctor,
bladder.
doctor, 1 second. See my colleague, she speak about the urethral and the password. Really, I'm waiting. Any examiner is waiting. Why? We are a radiologist. If we didn't use our common language, we become useless. And this is the right for the examiner to demarcate you. Okay? Thank you, doctor. Go on.
Thank you. All
Go
right.
on.
Um, yes, so summarizing my findings, there is no significant obstructive uropathy. However, there are bilateral ureteric calculi in the region of the ureteroceles. I will convey my findings to the referring clinician for the management of these ureteric stones. Um,
And
Otherwise, yes, and there was also a stone in the left upper pole in the control film, and also calculi. There is, however, I want to see the other images to delineate the urinary bladder properly.
okay, doctor, uh, do you think I will regret my word again? Because there are a stone here. I think my
Yes,
colleague, this stone may cause here hydrochalicosis.
obstruction.
Here,
Yes,
yes, may cause. Sorry, sorry, it may cause some hydrochalicosis. Okay, so this is a bilateral duplex kidney
duplex
with,
kidney,
with
bilateral ureteroceles.
okay, and a few stones. Thank you, doctor,
Yes,
so much. A fantastic case. I'm sorry. Our doctor is correct. This stone cause not hydronephrosis. It is localized hydronephrosis, so it named hydrochalicosis. Okay.
hydrochalicosis.
But anyway, there are a back pressure here, and this stone is need to be removed. Thank you, doctor, so much. Next
Thank you,
candidate.
doctor.